Aloha class, my name is C.Adams. I did my project on familial hyperlipidemia, otherwise known as familial hypercholesterolemia. And I thought it was an interesting topic because high cholesterol is something that we see often in the hospitals. A lot of our patients that we encounter are taking statin drugs and are at risk for heart disease. And so I thought it would be interesting to learn about some genetic factors and alternative reasons for someone to have high cholesterol. Just as a quick overview, familial hypercholesterolemia (FH) is a genetic condition that affects the body's ability to clear cholesterol from the blood. It results in critically high LDL-C, which LDL-C means low density lipoprotein cholesterol levels, and a high risk of coronary artery disease. It occurs in 1 in 500 individuals. It can occur in 1 in 100 individuals in certain ethnic groups. Over 600,000 people are living with FH. At least 90% of them have not been properly diagnosed. FH is treatable and it can be managed through diet, lifestyle modification, and the required use of medication and consistent support and monitoring by a medical provider. This condition is much more complicated than just having high cholesterol levels. It does not result from poor diet and lack of exercise alone. Those factors contribute to high cholesterol, but it's mostly related to genetic mutations that affect the liver's ability to dispose of or metabolize LDL. And LDL is also known as bad cholesterol, by the way. But the mutation affects the LDL receptors. And that was first identified by Joseph Goldstein and Michael Brown in 1973. Eventually their work earned them the Nobel Peace Prize. It's important to know that FH is an aggressive condition. It requires pharmacological intervention, along with a lot of help from medical providers and constant monitoring as well. Only 10% of those living with FH are properly diagnosed and treated, according to the FH Foundation. Most people, unfortunately, don't know that they have FH until they have a heart attack, and that statistic also includes young children and teens. FH is more common in the French Canadian, Ashkenazi Jew, and South African populations. Okay, there's two types of FH, heterozygous and homozygous. Um, Heterozygous obviously seen on the left and homozygous on the right. Basically, the inheritance of one mutated gene would classify an individual as being heterozygous, and the inheritance of the exact mutated genes from both parents classifies an individual as homozygous. So because FH is a genetic disease, most individuals with FH are born with high cholesterol levels. Um, Homozygous FH is much more serious and it's much more difficult to manage. The Journal of Lipidology documented that children of one heterozygote parent carrying the faulty gene have a 50% chance of inheriting it, while children with two heterozygote FH carrier parents have a 25% chance of inheriting both defective genes and developing FH. Homozygotes have a higher elevated LDL levels, as you'll see later, and they have an earlier onset of heart disease as opposed to the heterozygotes. Moving on to genetics, um, the genetic mutation that's specific to this particular condition occurs in chromosome 19, and it affects the LDL metabolism in the liver. Genetic mutations to three specific proteins are most concerning because of their involvement in ridding the blood of the low density lipoproteins, or LDL. Through the continued advancement of genetic technology, more mutated genes are being identified, and there are a lot of possible mutations that can occur. But more specifically, we're talking about the LDL receptors, the PCSK9, and the ApoB proteins, and the genetic mutations that occur in chromosome 19 specific to those three. As seen in the picture on the far right, LDL starts to accumulate in the arteries and other parts of the body, creating visible bumps, skin discoloration, and narrowing of the arteries. And this is a result of the body's inability to rid of the LDL in the liver. PCSK9 is a protein responsible for regulating the amount of LDL receptors on the cells. It plays a role in regulating blood cholesterol levels. ApoB is a protein that plays a role in binding the LDL to the LDL receptors. And the whole reason why this genetic mutation and this whole condition, this disease, is so serious is because it contributes to heart disease. And if we do not act quickly, if diagnosis doesn't happen quickly and intervention doesn't happen quickly, unfortunately, it's common for many to die before the age of 30. Laboratory diagnostics. For those with heterozygous FH, they may have less visible symptoms than those with homozygous FH, which is the more serious form of FH. The target goal for LDL cholesterol after the diagnosis and therapy is less than 100, and it could go as low as less than 70 for those who've had a heart attack before. And the optimum results are achieved through pharmacological therapy and the regular monitoring of their cholesterol levels. So for a heterozygous FH patient, for a child, we're looking at LDL cholesterol levels greater than 160 to be diagnosed with, or to start the diagnostic process for children who we think might have heterozygous FH. And for adults, it would be greater than 190. For homozygous FH patients, we're looking at LDL cholesterol levels greater than 400. As you can see, it's a substantially higher level as compared to the heterozygous FH, as well as the normal findings. Optimum LDL cholesterol in an adult with no risk factors should be less than 100, and an acceptable LDL cholesterol in a child would be normally less than 120. Here are the clinical manifestations of various symptoms that patients with FH or individuals who think they might have FH could be experiencing. We have xanthomas, corneal arcus, xanthelasmas, chest pain or angina at a very young age. That's a key word, at a young age. Premature atherosclerosis, cramping of both legs while you're walking, sores on lower extremities that are unable to heal, signs of a stroke, and one common one is little to no response to cholesterol lowering medications. Here's a picture of a xanthoma on the knee. Basically, xanthomas are collections of cholesterol under the skin or tendons, and this occurs because the body is unable to get rid of this cholesterol. So it starts to pocket up under the skin in various parts of the body. So they're usually yellow bumps that can be small or hard to see, or they can be large, as you can see in this picture. They're often found in the folds of the skin and buttocks in children. There are also xanthomas on tendons and ankles and hands. As you can see here, you can see it's pretty obvious in the knee and elbow, or the ankle and the elbow, I'm sorry. During a physical exam, it's common for providers to feel the thickness of the Achilles tendon if it's not as obvious as you see here in this picture. A lot of times, providers will feel for it if they think or suspect that a patient might be at risk for FH. They could feel for that thickness. They can also verify the thickness via ultrasound or MRI, and that can serve as an indicator of FH and start the diagnostic process. This is xanthoma in the hands. It's a more obvious form. You can see, obviously, there's a cholesterol deposit under the skin, this large lump of accumulated fat under the skin. But it's not always that obvious. In a lot of the journals that I've read, usually for children especially, this is the first sign of FH. And what helps them lead them to an eventual diagnosis is this discoloration in their hands. As you can see here in this picture, it formed these yellow or orangish yellow colored in the creases. And then another symptom is, or presentation is a corneal arcus, as you can see here. It's a grayish white ring of cholesterol that forms around the iris. Um, at a young age, it can indicate homozygous FH, but since this finding is kind of common in African Americans, this presentation only serves as a diagnostic tool for FH in those that are younger than 40. This is a xanthelasma, which is cholesterol deposits under the skin, around the eyelid, or surrounding areas of the eye. It's painless, and it can be surgically removed, but normally they return if cholesterol levels remain unmanaged. Now moving on to treatment. Statins inhibit the enzymes that produce cholesterol, so it's always the initial medicine of choice in highly aggressive treatment of FH, especially for those that are diagnosed with homozygous FH. Higher potency statins, as atorvastatin and rosuvastatin, are used first, and the intent of doing so is to reach target LDL cholesterol goals. And these high potency statins are also FDA approved to be used in children as well. I didn't know that. And if needed, then they would add on other drugs to achieve the optimum results, which is why I listed the cholesterol absorber, the bile acid sequestrant, and then there's other lowering medications, which includes fibrates, niacin, phytosterols, fish oils, other vitamins, and PCSK9 inhibitors. For children with heterozygous FH, treatment is usually initiated when the LDL cholesterol is greater than 160, and then the target for them would be to get it less than 130 after the treatment. Unfortunately, for children, adults with homozygous FH, pharmacological treatment may not be enough to achieve the normal LDL cholesterol levels. But recently, the FDA approved 2 new drugs. One is lomidopide, and the other is mipolmersen. And this is to be used for homozygous FH patients that haven't successfully been able to lower their cholesterol using the statin drugs and other medication therapies. Another option is what's known as LDL apheresis. And it's initiated in patients who do not respond well to all the other conventional treatments. It's similar to dialysis in that the blood is drawn out of the patient using a catheter, and then it's processed to remove the LDL particles to reduce their LDL cholesterol levels. And then in the worst case scenario, liver transplants are always an option, but it's always hard to find you know, a donor, because a lot of times a family member wants to donate their liver, but then because it's a genetic disease, it's difficult because they may have similar liver malfunctions as well. And then at the bottom here of the slide, you can see the diet and lifestyle modifications I also included. You can see a typical US diet and what is expected of a patient with FH to have to make some type of diet and lifestyle modifications. It's really hard. And then testing and prevention. Once a patient is diagnosed, there's a lot of tests that are done to help them be treated, but mostly it's done to help their family members. So DNA genetic testing is not required, but it helps to identify the mutated gene, and then cascade screening is done to identify other members of the family that carry the affected gene to allow for diagnosis and treatment. And then there's non-invasive imaging, as you can see here, which allows for providers to determine the degree of atherosclerosis and strategize their treatment options. Lastly, if you could just watch this video about this woman living with FH, It's really inspiring and it gives you a lot more information about how it feels to live with FH. Thank you so much.